Everyone, let's go ahead and get started. I've been trying to keep track of who has logged on as we go here. So let me go ahead and do roll call. So I'm Kim Taylor, I'm your board chair. I am here. Is Andrew Van Winkle here? Okay. How about Craig Davenport? I know you're here.
Yeah, here.
Perfect. Gail, I believe you are here.
I'm here.
Perfect. Let's see, Jill Burkholder. Yep. Jill, could you go ahead and Jill, would you go ahead and respond if you are here? We'll hold off for Jill for just a second.
I'm here.
Chris, oh, perfect.
Can you
Thank
hear me?
Yeah.
Okay.
I'm
I'm having trouble with my internet, so I apologize if
Not a problem.
if you can't. Okay.
How about Chris Thompson? Okay, Lori Moon.
Yes, here.
Perfect. Thank you. Lita Phillips. Mark Bullock, I know you're here. Dr. Limburger, I know you are here. And Shane Michael Lindsley, I know you're here.
Yep.
Perfect. Okay, so it does look like we have a quorum. Just to go back through again very quickly, has Andrew logged on or Chris Thompson?
He's they're both they were excused.
Oh, okay, got it. Okay. And then Chris Thompson or Lita Phillips?
Lita is the only one that I did not hear from.
Perfect. Okay. All right, let's go through the rest, some others as well. Do I have anyone here from Spokane County Community Affairs, Cat at all? Nope. Jessica Thompson at all? Josh Henderson, I see is here.
Hi, Kim.
Hey, Justin is here.
Hey, Kim.
Hey, Katie, I believe is here.
Hi there.
And Nancy is here. And then Tom is here. Who have I missed? I'm seeing an Ellie.
Hi, I'm from Chaz, and I'm just listening in on the meeting about the Opioid Abatement Council.
Oh, perfect. Thank you. Nice to have you here. Thanks for coming. Is there anyone else that I missed? Okay, perfect. All right, if everyone could take a look at the minutes from last month, or from our last meeting, excuse me. Review those briefly, and please alert us if there are any needed changes or corrections. And in the absence of needed changes or corrections, could I get a motion to approve, please?
On motion to
Thank you,
approve.
Shane. Second.
Second.
Thank you. That was Mark. Okay, sounds good. Let's go ahead and move on to Gail.
I think we need to vote.
Sure, we can vote too. Second, how about a vote for approval?
Aye.
Aye.
Perfect. How about any no votes? Sounds good. Motion approved. All right. Gail, the floor is yours.
I think you're muted, Gail. Excuse me.
You're right. I was. You know, that's so unusual for me not to know I'm muted. So hopefully this PowerPoint will work. For some reason, when I share on Nancy's screen, I lose some of my visual controls. This won't be long. This will be a brief overview, but I think that there's some interesting things that are here. Okay, so next slide, please, Gail. It's not going anywhere. There we go. I guess I have to use all of my tools. So this is the Office of Behavioral Health Advocacy, and of course, my name is Gail Kogel. My pronouns are she, her, and hers. And so this is an excerpt from the report that we made to Department of Commerce. That's the one who funds our office. And I just took out some pieces from it because I thought these were good to know, be aware of. So the first bullet says that our services have really, really increased during this past quarter. And, you know, the regional and statewide offices responded to 366 cases just during the quarter from April to the end of June. And that's up from 316 in the previous quarter. And the Spokane region led the growth in demand for services with a 46% increase in number of cases. And I can tell you that I have felt that. The statewide office and 10 regional sites, we continue our efforts to solidify our systems and processes, and including troubleshooting and integrating of our database. Now, there is still some little kinks to work out with it. And I'm not sure why that is. I'm not familiar with the database that we are using. We've been told that there might be upgrades available, but at this point in time, no. And it's really hard for me to pull any data from. There's people working on the back end of it. So when you see the information I'm going to share, it's just kind of an overview because it would have been too painstaking for me to go in and get all of the information. And I frankly don't have the time. So I just want to let you know that things have been more challenging because we have lost some staff. We've had some turnover. We've had some have gone up on medical leave. And I think the turnover that we had was because the workload has been so much more intense than people previously experienced when they were in ombuds in other regions. And, you know, I'm not sure why that is, if their office did things differently. I can tell you that in the Spokane region, nothing is done differently. We continue to reach out and talk to people, answer the phones, but it has just been maybe the overall efforts of trying to reach people and let them know about the changes and that we're available. I'm not sure where it all comes from. We are starting to collect information about how the caller learned about our services, and sometimes people will tell me, and I don't always ask it, but people will tell me that their therapist or their provider suggested they contact us, or a family member knew about it, or they Googled it. And I know that many of the people that contact OBHA do contact the main office. But in our region, it's primarily they're contacting this office. And I'm not sure. I think that might be because I think is the 477-4666 number still being maintained? Because it does give this phone number. And if that's the case, I'm glad. I hope it is. Because that way people still call that old number. And this way they can at least get here. So actually, Pure Washington's launch ramp up of OBHA over the past 9 months really has been a success. We've met all the core project milestones that we said we were going to do in our contract. Don't ask me what those are, but I think they have to do with just our outreach and the people that we were trying to reach. Unfortunately, we have not received enough funding. So we have a substantially lower funding level than we had originally been forecast. And this has really impacted our program development and our capacity. So we're working on that. There's some activities that we've had to curtail because of that. It's kind of a sad thing. So here is just, you know, these are current open cases. I didn't have the time to go in and say when I close a case, it's for this reason. So currently open, and this has I don't know when, some of these were open a while back, but there's 51 open cases, and 17 of those are somebody with a complaint. That doesn't count the complaints that have been closed. But it's good to remember that OBHA distinguishes complaints as at the provider level, whereas previously we call them all a grievance. But now the grievances are counted if they reach the managed care organization level or the BHASO. In this case, it would be Spokane. But as you can see, for us, in our region, physicians, ARMPs, and medications continue to be a driver of the reason people are calling. And, you know, I also prepared a written report. I'm going to send that out to Nancy so that you can all read it, and it has more detail in it. Also with some examples of why I'm seeing that, but I just wanted to let people know. So the other thing I wanted to remind people of is that every second Wednesday from 3 to 4:30, I host a behavioral health forum for our Spokane region. And they focus on the regional behavioral health system of care, and they're open to anyone who has something to say or wants to be heard. And so this allows us to report our friends, excuse me? Okay. And to local, regional, and state leaders. And I haven't really had an opportunity to prepare those reports for Spokane BHASO, but I will. It's like I said, it's been crazy. Here's some of the feedback I wanted to share that, and I think a lot of these are not going to be too much of a surprise. Wait times are too long. There's no step down for youth coming out of inpatient services. And I heard this a couple of times, and particularly in rural areas. And there's no transportation for folks that live in rural areas. Also, and it's not listed here, but the choice of providers of where they can go in the rural areas is very limited. So if they didn't get along with a particular therapist or the agency, then their options are not great to go to someplace else because of transportation. One person brought this up a couple of times, that there's a gap in care between people coming out of jail and into housing, to programs. They said, you know, people incarcerated leave with what they came with and do not have resources to or prior or at the time of discharge, and this could include a phone. So I'm not sure how navigators work with this, but I do know that this is a person that was working with people discharging from the jails, I think at Geiger. This person is no longer doing that. They moved up in the organization, but this is something that they were real concerned about. And so as a result, people were saying, well, why don't you convene a meeting between the service providers and jail administration? You know, maybe that'll come about at some point in time. So trauma is experienced because of sexuality, abuse, neglect, molestation are complexities to receiving appropriate services, and providers that have been sharing saying that they're seeing more complex cases coming to them. July is Minority Mental Health Awareness, or BIPOC Mental Health Awareness. And so the July forum focused on that population. I wasn't able to secure a guest speaker for that one, but I thought we had some really good pieces of information. And this is just two highlights from that. You know, one person said that they feel like providers keep putting up barriers. They also made the comment that when they are seeking out services, or I can't recall exactly, but they were told, oh, you're only here because you're looking for a Social Security disability. I mean, and this thing still gets said. A 14-year-old Hispanic individual was taken to a hospital emergency department, and the grandparents didn't speak English. She was misdiagnosed with bipolar disorder, and as a result couldn't enter the military, because even though that was a wrong diagnosis. Down, boy, down. So anyway, even though we all know that these follow us, if it's an incorrect diagnosis, we know that these follow us. So on the horizon for us, so the demand for services has, like I said, increased since last October, and it's becoming more difficult to meet all the needs of people seeking help. And in addition, the cases are often more complex than previously experienced. And it's hoped that with securing the funds needed to meet the needs of not only Spokane, but all regions, we'll be able to hire additional staff. And we will hire a behavioral health advocate in the near future. Currently, I'm wearing two hats. I'm the behavioral health advocate for the Spokane region, and I'm also a program director for the East regions of the state that includes Southwest region. So it is kind of a caseload. So I know that was very short. The written report contains a little bit more detail. But are there any questions? Anything anybody would like me to expand on?
Gail, this is Kim. Do you have a sense of, I know you've talked about the increase in numbers kind of across the state and certainly in our region as well, but just from the forums that you've done or and maybe not from the forums, but I guess in the sense of the cases that you've had, have you seen a particular increase in a particular type of complaint, I guess?
I
Do you see
think
any patterns or anything different than previous?
there is, and I think it's specific to one provider who left an agency who was a prescriber that maintained people for some number of years with benzodiazepines, and then left that. These people were maintaining, they had pretty complex diagnoses, and they had a lot of high needs. And when that person left, the new prescribers wanted to titrate them down right away. And people were having withdrawal symptoms. They were also feeling like they weren't being listened to. And so it was hard for some of them to get back to that stable condition. Some still have not. So that's one of the issues on a particular provider. Others are, and I know that, that would be, hopefully that's going to be dissipating, or that's going to be taking care of itself in the future. But right now that's been an immediate, it just kind of goes across the board. It's hard to say that one is more than the other. I know that people often feel like their services they're being discharged before they're ready. And that's another concern that people are expressing, that I'm not ready. Why are they trying to discharge me? I still need this. I still have goals on my treatment plan I haven't reached. So why are they trying to discharge me? That's another comment that I've seen. Does that help?
It does. Thank you.
Also, of course, when you're inpatient and all the things that go on with somebody who's inpatient and not being real stable or not understanding everything. So when they reach out to me, that's okay. But that tells me that inpatient providers have the information posted so that someone can contact our office. And that, I still think that's a great thing. So
Gail, in reality, are those concerns about being discharged early real?
yes.
And what can be done about it?
Well, what I think is that in good practice, a good practice is to already have your exit plan when you come into services. What's it going to look like when you are on the other side of the services? How are you going to fit into your community? What goals would you like to achieve before that happens? And so people may not always be expressing what's going on with them. They haven't really maybe spoken all the way about it, but it has to do with, I think it's a miscommunication. Maybe the planners, the supervisor and the therapist are, it's this many months. Are we ready to discharge? And people get fearful of that talk because now they maintain some stability, and what they hear is they're trying to discharge me. But that might not be the full intent. It's a communication problem in some cases, most cases, not all.
So as an advocate, do you have influence over premature discharges?
I don't have any influence. The only influence I have is bringing somebody's voice forward. But I think that that's the important part of it, is to remember that when I'm contacting somebody, it's not me, it's the person, and it's their voice. And so, knowing the laws, knowing the rules is real important. And that gives me an advantage, but also having a good relationship with the providers.
Right.
But if I tell them, no, this person doesn't want to be discharged, you can't, I don't have the standing to tell them not to do that.
Right. I appreciate what you do. And just to put it in perspective, I'm curious, what is your caseload?
I have 51 open cases right now.
Okay. Thanks.
Some of them honestly need to be closed. And it's just going back to do that. But then I get 5 calls in a day, and it's hard to go back to those others. So Some of it's on my end, needing to clean it up. But yeah, I have a lot of active cases.
Gail, this is Justin.
Hi.
You're still covering all of Eastern Washington, right? From
Yeah, I have oversight for North Central, Greater Columbia, and Southwest regions, including Spokane region. So I
Yeah.
don't tell you how many counties that is. That's a lot of
Yeah.
counties.
it's over a dozen, I think. So yeah.
it is.
So Gail's a little overworked, to say the least.
Fortunately, there are behavioral health advocates in those regions. We're hiring one. One of the places we saw some turnover was the Southwest region. And again, I think it was the intensity of the job. The person really wasn't ready to do that. But we have a good person in place that's coming on board at the end of the month. And so for me, it's primarily the Spokane region that's giving me the headaches. And as soon as we can hire someone for my position, so that would be, when I know that's going to happen, I'll give a couple people a heads up so that they can spread it around. But yeah, you're right. Half the state and Southwest. It's a lot. Any other
Are there-
questions? Okay,
Yeah.
go ahead.
No, I was going to say, yeah. Are there any other questions or comments for Gail?
Thanks, you
All right.
guys.
Yeah, Gail, thank you very much. Appreciate it. All right, next on the agenda, let's see, we have some administrative updates. Let's start with Justin and some block grant plan reviews.
Yes. Thank you, Kim. Everyone, bear with me. It's the annual review of our mental block grants and subsidy block grants. I know they are extensive and long-winded, so I will try to go through these with as much alacrity as possible. Please come forward with any questions. I will do my best to be able to provide those. Nancy, can you pull open the block grant plan? Base block grant plans? Excellent. This is the mental health block grant, I believe. Yes. So, base block grant plans. Give a little background on this. Every year we have and do submit to the BHAB our block grant plans. Now, most of them already have assigned funding because it's continuation of existing funds already approved. So we try to continue those so that projects and services already continue. Then there's new and additional funding. And so what we are presenting to the BHAB is both existing funding that's being continued and ongoing funding. Now, the BHAB plans are different than contracts. The BHAB board is not approving the contracts. They're providing their feedback on the plans, which drive the contracts. So I want to be clear on that. Any advice given by the BHAB is to support contract that the Board of County Commissioners have already approved and or will approve, and or to express their concern towards how the funding is being utilized, if it's different or distinct or separate from what has been designated previously during previous BHAB boards, or where we project the funds to be utilized. So I have a couple different updates on that aspect. Funding for the mental health block grant base, and let me clarify that. So I use the term base because historically we've presented funding that has been maintained or separate, distinct every year from SAMHSA. That's where the block grants come from. And the funding has not changed. During the COVID years, they actually gave us COVID block grant funds and then ARPA dollars this July, which are the American Rescue Plan dollars. Yes, those came a year ago, 2 years ago, and we're just now receiving the block grant dollars from that. So you're seeing this subsequent follow through of funding. The COVID dollars are done. They ended June 30th, 2023. So we're not going to be discussing those. Those are done. The state and the federal government took back unspent funds, and the BHAB gave their feedback on those. So no continuing of those. ARPA dollars, which came during the COVID years, are the American Rescue Plan dollars. Those will be discussed today as well. And then the base block grant, or the continuation of existing funds, is what we're discussing right now. And that's the funding that the BHAB has had over 15 years of involvement in and have given feedback. And some of the program plans that have been developed are a continuation of those plans that have been existing during that period. So we'll talk about base plans and ARPA dollars. COVID have been discontinued. So before I jump into that, any questions on those funding sources or the background? All right, hearing none, we'll go into the base funding first. And I just want to confirm our continuation of existing BHAB funding priorities. So what we've been paying up to this point and want to continue are existing funding sources or contracts to serve members in the community. The first part of this plan are our narratives, the background, the continuation of specific vulnerable populations, examination of service areas, and then critical areas that the healthcare authority looks at, payment responsibility for individuals, so on and so forth. Those narratives just speak to the complexities in our system and the needs that exist. They aren't specific to any BHAB priority, only informs those priorities already chosen by BHAB. So you're not going to see much change in the narrative. I think we all agree a lot of the same aspects in this year are the same as last year. We still have a lot of fallout from COVID and the impact of the community. So some of those were conveyed in these narratives. And really, the ongoing workforce challenges associated with subsequent 5 years of issues, and then also with the needs assessment that still exists. We haven't solved a lot of issues in our region. We're continuing to treat those. Some of those have continued. So that's what you're going to see in the narratives. So like I said, nothing of significant change to stand out, only that we reduce some of the direct issues with COVID or reductions in direct person-to-person contact. Those have increased. Those challenges have been removed, and more of those associated with face-to-face contact, which have increased, and reduction of telecommunications, which has decreased. More and more people are going in person or in community. We basically responded to those specific needs in our narrative. So Nancy, can you scroll down between the needs assessment? The needs existed, so we're going to continue those. Stop there. Cultural competence and children's services. We don't do a lot of children's services. Most children, almost 98%, are covered by Medicaid. So the non-Medicaid services are limited and are not to be utilized and cannot be for non-citizens. Federal dollars can't be used for individuals who are not residents of the nation. So unfortunately, we have very limited scope in that area, and we have not seen in the last 5 years any youth utilizing these services other than childcare services, which are still fully funded. So that's one of the areas we highlight. Continue down. And I want to be clear, childcare services are, stop there, Nancy, are for those supporting Medicaid and non-Medicaid individuals receiving direct services to pay for their children to be in childcare, so that that isn't a barrier. We'll pay for all childcare, but Medicaid will pay for the direct service for the individual. We've committed to that. Behavioral Health Advisory Board involvement outreach. So the ASO actually gets money directly for the BHAB, and then we also pay for the Consumer Consultation Panel. We're the only agency in our region, including the MCOs, who pay for direct community involvement, including direct consumers and the Behavioral Health Advisory Board. As far as I know, and Gail probably is the expert on this, we don't have the MCOs having a separate and distinct consumer panel for members across the entire region. So we spend extra money to support those, including the Jaunt and June. That's what part of this identifies.
I would support that. I'm not aware of any MCO that has that.
And we're not going to shirk away from that. We've continued to increase our support. In fact, if anything, I've asked Gail to be more involved, including my staff. I want to see more in that area. So I envision more in that area, but we had we basically highlighted that we need more. We need more community involvement. Outreach is our primary. So again, we highlighted that as being our component. Staff training, there's a small component that goes to training all contracted staff that provide a service. It's important that members who receive care have competent staff. So we ensure that portion of it, including cultural diversity, equity, and inclusion. Continue down. Program compliance, we adhere to all federal requirements. We're the only ones. MCOs get an audit, but we actually get audited by the state, the federal government, and local entities. So we're probably the most responsive to taxpayers. And then cost sharing. This is a core component where if a member who is receiving private insurance has to pay a deductible, we actually will enter in an agreement with the provider to pay their deductible if they can't pay it. So even if they're getting private insurance and we're not paying the service, we'll pay their deductible so the member is not receiving any payment responsibility. So that's what cost sharing goes to. There's a lot of federal requirements on that, but we do that and commit to that. So members or community do not have to pay anything, and we're committed to that. You're going to see this same aspect in each one of these. So this is the only time you'll hear this. The response on each one of these is similar because they affect all similar areas. But I wanted to go in detail in this area, and then in subsequent plans, you're going to see similar language. So if you have any questions, ask me now. Otherwise, we'll defer to just project plans moving forward. Any questions? All right, so that's our narrative. It does not drive the plans, but it does inform them. All right, so Nancy, can you open the summary and expenditures? So in this, we hit key areas that we're already funding. Remember, these are already commitments made last year by the BHAB. We're just continuing to fund those. We get a very small portion of mental health block grant, so we don't get any additional allocation in this area. So for assessment, we pay for STARS to have co-occurring assessments. These are for any non-Medicaid individual, core area. Key, scroll down, scroll down, scroll down. Right here, individual therapy. Frontier provides our primary direct treatment services for non-Medicaid individuals. This includes elder services and all other encapsulating outpatient services. The reason we went with FBH is historically, they're the catch-all for most of the referrals from Eastern State Hospital, jails, and hospitals. They're the largest organization. We've talked about expanding in the future, but remember, we only get a small portion, and they've expended almost all of their funding every year. So in this area, it's hard to take away from one to give to another, which is why you continue to see Frontier in our individual therapy. That's just outpatient services for mental health, non-Medicaid. Group therapy, we have STARS. They have a wide scope of co-occurring services for groups, so we continue that service as well. Scroll down. For medication management, the primary focus has been rural communities. So for Stevens County, which includes both Ferry and Lincoln in terms of their coverage area, we've expanded medication management. This allows for a nurse practitioner or a psychiatrist to actually prescribe medication for those exiting out of an inpatient setting to receive one service of medication management before their insurance kicks in. So we'll pay for that first one, so they're not on the hook, and then they'll continue to receive services as part of their they're either Medicaid or non-Medicaid commercial insurance. Very rare do we have people that don't receive that, but for those that do, we pay for that first service. Usually coming out of a jail, they have a disruption in services that period of time. We try to cover that first case so they get uninterrupted medication, continued service. In psychopharmacology, last year, New Alliance reached out to us and said, a lot of those people can't afford their first medication. So they're getting prescribed, but they can't pay for it. We said, let's pay for it. So you'll see an extra $10,000 to just pay for their medication until their insurance kicks in. This is a wonderful service for rural individuals who could not afford their medication. We're going to pay for their psychiatric medication. can't pay for their medical services or their physical health medications. But it was a request we received, and we're going to cover those. So that's a relatively new addition, but it does continue the existing one. Continue down, continue down, continue down, continue down, continue down. Stop there. Case management. This can, again, provides for case management for a co-occurring aspect with stars. Again, continuation of something already provided. Continue down. Stop there. And then for recovery housing, this provides supportive services for rural members in the highest population center of Stevens County for emergency stabilization. They're not a stabilization center under the Department of Health, meaning they don't provide the whole bevy because they can't provide the same level that a stabilization center like SRIC can provide, but they do provide immediate emergency placement in a bed and some nurse staff to be there with them. So they have to be stable. They have to have medication already on board, but they're provided a space before they go home. Again, providing critical resources in a rural county responsive to their needs. So continuing that service. Continue down, continue down. Stop there. The Evergreen Club, we're continuing that valuable service at FBH. That is a critical component to some of the services we provide in the region. That is not being touched. So we're going to continue that and then continue down. We're stop right there. We're also continuing support for SEER. As indicated last year, we had increased their costs. They had increased costs, so we increased their funding. That's being continued. So those who aren't familiar, SEER provides supportive education for those with mental health and substance use issues. This is where it may impact their learning or learning environment. They provide a very supportive engagement specific to that, not cognitive or neurodevelopment disorders. Those are provided separately. This is specifically tied to, I have anxiety, depression, substance use involvement, or a combination therein. They provide support. We actually increased it because they saw a need in that. They've been able to support new devices, which was something BHAB identified last year for some of our additional funding. So they got all new computers, all new iPads. They were running on equipment from like 2010. So they've expressed significant appreciation to BHAB for supporting that. And they trained all of their staff, including additional ancillary staff in other departments on mental health first aid and working with individuals and supporting individuals with mental health or substance use involvement to, again, further the recognition of the stigma attached to mental health and those in education. Amazing, because everyone came back saying, we didn't know this was so challenging. BHAB supported our initial investment in that, which was an additional $20,000. They want more. We didn't have any more, but we're continuing that same support. So thank you all, BHAB, for supporting us last year. We hope to support that moving forward if we get additional funds. So love it. I can't speak enough about that. I want to expand. Continue on, continue on. And not this section, next section, next section. We don't have enough to support these ones, unfortunately. Next, okay, stop. So that's all we can support with the existing funding. There's a certain admin expenditure that goes to support the staff, fiscal staff, the administrative staff, and my program staff. We don't necessarily always utilize all of that. It's only what is used and not necessarily what's allocated. As you can see, it's less than 10% of the overall funding goes to actually admin. Most of it gets pushed out. That's our commitment to funding the providers in our region. So I'll pause there. If there's any questions on mental health block grant, we have 3 other plans to go through, so bear with me here.
I have a quick question, Justin.
Yeah, go.
Could you just tell me a little bit more about the cost sharing for like the deductible, or if I remember, I think that's what it was.
Yeah. So really the only provider who has taken this up on us is the OTP, or opiate treatment program with SRHD, and it's pretty much with SABG. So we haven't had anyone use it for the mental health block grant,
Okay,
but for substance abuse, Medicaid pays for opiate treatment. And so so does commercial. What we found is commercial will not pay for any responsibility on the individual side. So we said, fine, if you enter into a cost sharing, we will pay up to a certain amount of the individuals up until they're paid out. So if you have commercial insurance and you say there's a deductible of $500, right? And you have to pay to a certain amount. Let's say you're on the hook for 300. We'll pay your amount for each treatment up to the 300. And once that hits and your commercial insurance takes over, we'll stop and your commercial will pay it. Ostensibly, the provider gets paid, but the individual never sees a request for payment. But providers have to enter into that agreement with us, which means they have to report it. If they don't, then we can't pay that. But there's stringent rules federally. And this is the challenge we have with parity. Because on the physical health side, they don't have the same rules, but on the behavioral health, there's a lot of barriers with individuals, unfortunately. So we are still working through that. But thankfully, that is not a barrier on the OTP side. On the mental health side, thankfully, most of our services are almost all encompassing. So even if commercial doesn't pay it, as long as the minimum threshold for the non-Medicaid will cover it. So like Evergreen, we don't make any commercial insurance pay, and there's no copays. We just pay the full amount. So it doesn't apply. For group treatment, there's not many that pay for that. We pay all of it. And the individual treatment, we pay for everyone who's at or below 22%. So it doesn't matter. So at least on the mental health side, there's not as many restrictions. It's pretty much on the MAT or medically assisted treatment that it becomes a challenging aspect.
thank you. Yeah, I wasn't aware of that for some reason, and it's good to know.
Yeah, it's been creeping up, and we realized people were on the hook for that, and it was a barrier. So we finally convinced SRHD to take us up on it, and they were wonderful in supporting us. So we can say anyone who's receiving a treatment who's paid by us doesn't have to enter into any sort of payment responsibility for that side on the commercial. So
That's awesome. That's a needed service too.
Yep.
That's a needed service.
Nancy, can you click the block grant co-responder? You're going to see that we had $608,000 assigned, and you only saw 534 under the major block grant plan. The state allocated an additional 75,000 for co-responder funds. Now, this is very specifically tied to legislatively an amount given to a law enforcement or first responder agency only. Now, there are certain co-responder funds that are paid out by a mental health provider who provides it in conjunction. The state said we couldn't use these funds other than to a first responder. Now, we put this out to RFP. We reached out to the providers and to the first responders, said, will you take on $75,000? No first responder can take on a program annually for $75,000 to pay someone and administratively cover it with liability. The state just didn't allocate it. But since they won't let us use it for a behavioral health provider, we're limited. So, for example, FBH currently runs all of the 9 co-responders for Spokane County. They're paid out in grants from WASPEC, the Washington Association of Police Chiefs and Sheriffs, and with the Healthcare Authority. Those go to the provider, and then the administrative component through the Sheriff's Department only has to worry about ensuring that the money is put out, not that they're monitoring it. If we were to do it directly to the sheriff, they would have to monitor the Department of Health license, ensure that everyone's credentialed, and ensure all of the requirements for the funding federally. They don't have that capacity nor the experience. And so when we asked them, they said, no, we can't do that for 75. We can't do that for 200. And they said, can you give it to the behavioral health provider or let us just pass it through? And we said, we can't, the state won't let us. So you're going to see the 75 was unspent last year, was unspent the year prior, and is expected to go unspent. We asked the state to take it back and give it to a provider who can do it and free up the other money so we can make it given to the behavioral provider. They said, unfortunately, someone in the legislature allocated it a small amount, and they unwilling or cannot parse it out for the behavioral provider. So don't let this dissuade you. We are exploring all options for our existing funding for co-responder, and it is happening. Unfortunately, we can't unlock this one because of the restrictions on how it's utilized. And I give you this long-winded explanation because there's also that on the SABG. I won't go into detail. The same rules apply. Any questions before we switch to SABG?
It's a shame about the co-responder dollars.
I agree, because I would have loved to push it out.
Yeah.
And I tried for a year. No one would take the money because of the restrictions the federal government put up. So,
Wow.
but regardless, I still explored every option with other funding. So the service is still being provided. We just have money that can't be used for it. So don't worry, service is being provided. Nancy, can you open the SABG plan? Base plan, not the ARPA. As Nancy's opening that up, just a highlight. We have a certain amount of funding that was allocated. We were just notified last week that the state, because of certain legislative requirements, over allocated or over promised an amount, meaning this, the state gets a certain amount of federal block grant dollars, base dollars, and then the state can allocate a portion, and then the rest is allocated to us. The state or the legislature really over allocated a certain amount of that funding, which means there was less to give to the ASOs. Now, that meant our overall base amount was reduced, which means the amount you see in this one is not the amount that we're going to be finally receiving. They're reducing it overall. That's good and bad for us, meaning we get to lose money, but at the same time, I already planned for that, so we actually have no providers that will be impacted. So good news in that area, but unfortunately, it doesn't mean an overall reduction in our region. So I'll talk a little about what that means. So we had $2.1 million essentially allocated to us. They're probably going to reduce that to half. Unfortunately, that's the state is going to take that. It's still going to be used for other projects, just not for our region. For the plan narratives, they're the same. They are substance use focused, but they're the same in terms of the needs. So I won't cover those in detail. Nancy, can you go to project summary? This is how the money is being allocated, and I will reflect. We have a little bit more SABG, so the money allocated here is not as stringently tied. So your providers have not expended it fully. So just FYI. So for PPW, that's pregnant and parenting women, we used to have a contract with New Horizons. In the last 4 years that we had a contract with them, they never expended funds, despite that I repeatedly put out money. And simply because pregnant and parenting women and children are the highest covered individuals for Medicaid.
Mhm.
Now this year, that might not be the case because of enrollment issues with Medicaid re-enrollment. So we still are allocating money, but New Horizons terminated their contract with us, despite carrying it for 4 years, doing all the administration without taking any money, because they wanted to partner with us. They liked us, but they said last year it just was too burdensome. Good for us, meaning we demonstrated our connection to the community, but bad overall because we couldn't maintain a contract. I did get them to agree that on a case-by-case basis, we would still pay for people. No individual who needs our funding will go without it. But I just want BHAB to be clear. In 4 years, we had not had a woman who was not covered or their children by Medicaid. So you'll still see money there, but we haven't had a need. Outreach, that's still continuing, and providers have expended that primarily to individuals with opiate or intravenous drug use, including women. In this area, it is not restricted to non-Medicaid. Anyone can receive the outreach. unfortunately, the moment they cross over, it's limited. So that will continue throughout our region. Only caveat, we no longer contract with Daybreak. As everyone may have heard, Daybreak had a bunch of issues with the Department of Health. Their license got discontinued, and we terminated the contract to maintain safety for youth. Whether or not they continue, we will defer to Department of Health, but that's one change. We no longer contract with Daybreak. They did do they did do outreach and engagement. We expect that will continue with the Excelsior and other providers who are already doing that. But that's one area we won't contract from this point, really July 1st onward. Drug screening is still provided as part of all contracted entities. Not many use it because Medicaid covers it, but we do provide that. Continue down. Engagement services. This is an area where we try to provide as many opportunities as possible for non-Medicaid individuals, either interim, meaning before they get involved in a Medicaid covered service, for assessments prior to engagement, before services are covered by Medicaid, and then engagement. Anything from outreach engagement for peers to jail transition services. We are putting money towards that gap. We're one of the few in our entire state that do that. We're investing in continuing that based on BHAB's input. Scroll down. And our caveat, this SABG base is just a continuation of existing services. So now this is new, other than Daybreak being removed. Continue down. We pay for individual, group, and outpatient services. Continuation of all contracted entities for non-Medicaid. We don't see a lot, but we do have this service provided, including family therapy. Continue down, and the MAT is primarily funded through SRHD, specifically in the jail and in the community. So that's one of our biggest fund sources. Case management, we do that through various providers. Again, that is connecting them with services as part of existing outpatient. Continue down. We also try to support housing support, again, to continue them in housing if any issue comes up. Very rarely does this come up, but in the off chance that we have an individual transitioning from commercial to Medicaid, we support them. So we have yet to have anyone utilize it. Continue down.
Maybe you need to remind them.
I did. The state really, Washington State does a great job for pregnant and parenting women. So it's a very covered area. Let's just say that. There's not many that don't have funding sources. What we find is actually a larger portion of individuals who are just above the 220% federal poverty level, generally males who are unemployed or are partially employed, that the state doesn't cover. And unfortunately, we are limited. But the vast majority of pregnant and parenting women and children, the need isn't there. Sobering is. So I will say this, one expansion we did in the last year based on BHAB was we are now covering all Medicaid and non-Medicaid sobering services for Spokane County and for New Alliance, Stevens County. Why? Because Medicaid was not paying for it and the need was there. So we just said, we're going to pay for it. It's a non-covered service and none of the managed care organizations were going to cover it. So we are. So we're one of the only ones in the entire state doing this. And I researched this. Wonderful service. I'm hoping to extend it even further. So sobering is essentially the withdrawal management, but non-medical acute, where individuals are coming off any substance. You just need a safe place to be dropped off and do it where they're provided resources, food, shelter, out of the cold before they transition. We provide that. Insurance is not a barrier. So what a wonderful service. Continue down. Subacute withdrawal. They changed that language. They don't say subacute. They just say withdrawal management services now at different levels. we cover those for all non-Medicaid persons. So continue to do that. And we also provide intensive inpatient. A lot of people are covered, but we provide that. And then recovery house, we also provide that as well. Continuation. Scroll down, scroll down, scroll down. Keep scrolling, keep scrolling. Acute withdrawal management and subacute generally are the similar facilities. As everyone knows, ABHS's COSA facility closed, so we have Parkside and Chehalis. We also have STARS that does this. We pay for all of those services, subacute and acute. The difference between the two is medically managed with a psychiatrist. And some do, some don't. The Secure have one on site. The reality is, since they changed that language, it's all encompassing and not essentially the service or the need is the same. So they're trying to encompass all of that moving forward, all included for non-Medicaid individuals. Continue down. Continue down. Transportation, not the needed, but because Medicaid pays for it, but we do cover additional services. And then childcare, this is one of our largest areas of funding. We will not reduce this if it comes to reducing the cost for our region. In fact, we just met with CME, who assured us they're expanding it. So this is wonderful news. We're going to be looking to expand this. They provide childcare services, but Medicaid transformation was just expanded to include childcare. Wonderful. Finally, the federal government recognizes that. But it also means, what do we do with the existing funds? So I've been talking with CME for the last 2 years saying, I know this is coming, please explore. So they finally came up with various other learning opportunities, child safety engagement areas, learning collaborative corners, and then basically recovery cafe, but for children in an environment that's safe and therapeutic, and also one that responds to youth. For the kids already enrolled, that's going to be our expansion in the near future. So we are responding to the most innovative and new requests out there. Wonderful for our region. No one else is doing that. So all the money that is going to be replaced by Medicaid will still be invested in youth in our region. So that's exciting. And it'll be used for youth that don't have that existing opportunity. So although we have money that won't be utilized, it will be. And then we're going to pay not on a fee-for-service basis, paying for staff, outreach and engage in those environments. I'm super excited about this area. I've been wanting them to expand for years. And thankfully, we've been able to achieve that. So kudos to CME for working with us and exploring that. I will have them come speak to BHAB in the near future to explain that once it comes forward. But our region, our county, will see this opportunity that nowhere else gets. So super excited about that. And then other activities, education, these are ones where our providers come forward and say, we need support to either train our staff, look at our infrastructure, or even look at resources. We've expanded it this year for more training in our region. We do more training than other MCOs do to support specific targeted implementation. So we'll be doing that this year. Not only trauma-informed care, but also looking at motivational interviewing and essentially ethics and the necessary tools to provide treatment long-term. And then the ASO expenditures, as we discussed before, it's a 10% of contracted funding. We don't always use all of it. So we only use what is actually implemented. It's usually a quarter, if not half of what is actually posted. The state gets most of it back. We don't make money. We only ensure staff are available. We do so at cost. So that's what that number means. But we try to give like worst case scenario. We will never exceed 10%. We'll always do less. And the same with the co-responder. Same rules apply. They put $25,000 towards this, which doesn't make sense because it's less than the mental health component. We see more of that on the substance use side. Again, same limitations, which is why we didn't put it out. We simply said, please give us freedom. And they said no. And that's it. So, questions on that? Concerns?
That's a lot.
It
What's
is.
the grand total of the substance abuse? I didn't get that.
It's 2.1 million, but it
Okay.
looks after, so that's what the BHAB is approving now. After the state comes back in our meeting this week, it may be reduced an additional 500,000. So we're looking at probably 1.5 is our eventual amount. The core
Okay.
areas I told you we will not reduce are anything with PPW, childcare services, or ongoing care. So you're going to see more of the ancillary ones that have not been expended. The good news is we have 5 years of data to show what is being used and not. So any reduction will be unused monies. No one will be impacted.
Okay.
But unfortunately, we can't give you a number right now because the state hasn't released that yet. So it's a projected amount. Thanks, Tom. These are our base block grants. These are what BHAB's already approved over the last 5 years. Now we'll move to our ARPA dollars. So can you bring up the mental block grant ARPA? So to the BHAB, the ARPA dollars are a one-time fund source, a lump sum given for a period of time till 2025, June 2025, and then the state takes them back. They can't be used for existing block grant funding, so it has to be for additional, and they very clearly restrict these. So I had to get creative. We don't have any plans for these yet because they had to have us submit these. So I put those in areas, but the BHAB will still have input on how they're spent directly with contracts. So I want to be clear, there's only one provider where contracts were actually implemented with this funding. No other funding has been put in contract yet. So although it's assigned, it is not contracted out yet. We will have this discussion. And that's only the one associated with existing services already approved by the BHAB. So that being said, let's jump into it. Mental block grant has the same, ARPA dollars have the same restrictions. Nancy, go to the top of that, please, of the page. There's a certain amount of money for this period, meaning July 1st of 2023 till 2025. Top. So for that period of time, we only get $800,000 for just shy of 3 years. That's not a lot of money. We get more, about that amount in a 2-year period. So we have to be very diligent. We can't start any projects that won't be fully funded. And since we fully expended our mental block grant base plans, we didn't want to create any problems where we tell a provider, hey, do this for 2 years and then we have nothing. So that's our mentality moving forward. All right, Nancy, go down. For the first allocation bucket that I kind of conceptually put it towards is our engagement. Stop there. Educational programs for schools or community programs. This is anyone working with and or engaging with individuals with severe and persistent illness. We wanted to put money towards education, giving them mental first aid, motivational interview, anything to educate them on the challenges faced. So it's there as a hold. We don't have anything assigned, but I figured that's where BHAB has expressed before was a desperate need across our 6 counties. And then outreach, getting people into needed services, which is expansive, pretty much allows for any sort of education, training, and then connection. So you'll see the largest bulk here. And again, this is for almost 3 years. And so we're gonna try to identify providers. One area I thought was our NAMI project that we've discussed, and creating a position to be community-based that just works with people, all walks, to educate. And NAMI is a wonderful community-based organization that does a wonderful job on that. So that's a idea forthcoming to our BHAB group. Some of these are already covered, which is why we didn't. Warm lines, therapy, group therapy, family therapy. We already have enough money going to those, so I didn't want to overstack those. Some of these are, again, remember, all this is strictly regulated to non-Medicaid. So some of these don't apply. Stop here. Medication management, non-Medicaid people, or pharmacotherapy is limited because most people are covered under that. same as laboratory services. So we just restricted those, other than a small amount to psychopharmacotherapy, which is for our rural regions, so they can access that. Continue down. Again, a lot of these are direct treatment, which is already covered. So we really identify where's the need. And we didn't want to limit those areas. Again, those are all open to exploration in the future. Peer support, we got a lot of money for that this year. So we limited that in these block grants, but again, can be used in that area. And most of these are, again, billable to Medicaid. So we limited those, anything that could be billable. Go down. Respite. This is an area to support peer and peer engagement. So Passages Family Support is opening up a new peer respite center that will directly support individuals. We brought this forward before. This is the area where we're going to pay for all non-Medicaid individuals, and we're heavily investing. We firmly believe this is a resource needed. We want to invest in it. So we're putting the money towards it. So we're asking the BHAB to approve this because we really believe this is all-encompassing, non-coercive, non-barrier service that provides the greatest outcomes. And really, there's no other funding available for this. And transportation to get to those areas, including inpatient. When people are dumped out of their inpatient, even if they're Medicaid, they don't have transportation. We want them to get back home, especially for rural communities. So we are investing in that. I don't know what it looks like, but we want to invest in it. So that's where you're seeing the money in those areas. Go down, go down, go down, go down, go down. And I believe that's the primary areas we allocated. Again, we have a small amount. As part of this, we don't get an admin. We're going to use the existing ones. Again, our commitment to ensuring money goes to people. So you see the grand total for peers, community engagement for services not already covered by Medicaid, transportation to rural communities, and then outreach and connecting them to services. Again, key areas where no existing funding is currently going to any great extent, and we know we can cover it. As part of this money, there's also a crisis service set aside. So next tab, this is an amount that the state said, oh, you need crisis services. It's all going to our existing crisis network. So all of it, mobile and family youth and services, to expand and ensure people receive services. We want to enhance it. So existing services fully funded. Peer Pathfinders. Now, this is going to be a little interesting. We put money towards Peer Pathfinders, but I want to share a sort of a wonderful news. So I didn't like how the state kept making the provider wait on an allocation. And it's a one-time, meaning 79,000 for 3 years. That's not enough. So I said, we're going to fully fund it. So we did. So it's fully funded, Peer Pathfinders. This is only additional money to support that. So our existing program with Passages is fully funded through other sources in perpetuity, meaning there's no time limit. We continue funding it until we don't no longer exist. Why? Because I think that is the absolute necessity between jail and connection in the community. So although it's there, I want you to know that's only additional money. That's not core. We fully funded it. Kudos to Spokane because no other region does it in the same way. I'm very excited about that. And then additional CPC to MCR. Again, same thing. They restricted the funding on this. It's ancillary. We incorporated those certified peers into our crisis system from last year because I don't want the state to limit us. So you're going to see additional peers in our crisis system, and this is just to support them. Again, fully supporting them and funding them long-term is where I think we need to be. So we did it. So that's our ARPA dollars. Any questions on that before I move into our SABG ARPA dollars?
It's a lot of numbers to remember.
Yes. A key thing to remember is these ARPA dollars are one time. I hate when the state gives us one-time funds and says, start something, but we don't have any way to finish it. So I always work to finish something and then look how I can support these funds. That way a provider comes to us and we can tell the community, you're good for 5 years. You're not going to get dropped. All right, Nancy, open the last SABG. Sorry, guys, I'll go quickly through this one. It's going to be similar. Same thing in this one. We get a smaller amount, and we actually get more of the SABG. So I try to focus on what else we're not doing. So go down, go down, go down, down. Keep go. Oh, right there. Stop. PBW, again, that's a focus area. Always give money in case of challenges. Continue to support that for PPW programs. No children or women who are pregnanting who need services will go without it. Simple. I just won't allow it. Keep going. Keep going. We gave, oh, stop there. We gave quite a bit to educational and engagement. Again, we looked at what was not covered by the SCBG block grant and said, how can we support the community? If we're going to have one-time funds, we're going to do it to support the greatest amount of services without needing to continue them. We want to support community providers and other ones to do education, training, provide the tools to community members, including educational providers, so that they can have and be equipped beyond the scope of the funding. So we put the bulk of the money in this area. We will educate and inform, and so that anyone in the community can use the same tools to support the, and that includes co-responders, law enforcement, fire, EMS. So that's why you're going to see a lot more in this area. Keep going, keep going, keep going, keep going. I think that was the bulk of it. Keep going. Yep, I think that was it. Keep going, keep going, keep going, keep going. All the way to the end, Nancy. All the way to the end. Yep. So most of it goes into education, outreach, and training. And then the Peer Pathfinder section, same. We're fully funding that in existing funding. This is just to support additional costs. The providers being funded will not lose their staff when this funding ends. So that is both of the plans. Our ask to the BHAB, if there's no additional questions or input, is for approval to move forward with the allocations we put before you.
It's past Jimmy.
I move for approval. This is Kim.
I'll second.
All in favor?
Aye.
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 Aye. Aye. Great job, Justin. Thank you.
Thank you, Kim. And then I will quickly go to Josh and Katie for an ISW update, and then I'll talk about the OAC. I want to wrap up here by the 4:30 timeframe. So sorry, Josh and Katie.
That's fine, we get it. Good afternoon, everybody. Thank you for your time. We just finished our first year of our pilot program of the Initiative for Student Wellness. As a refresher, this is the program that uses a universal screener to identify behavioral health concerns to middle and high school students. And the benefit of the program is particularly to focus on those kids who might be flying below the radar in terms of the mental health support that they need. Really exciting and good timing with today. I actually just returned from Austin, Texas, where I attended the National Association of Counties, and our program actually received an award for ISW, and so we went there to receive it with my colleague Jessica Thompson and Commissioner Mary Cooney and Kat Nichols, our Senior Director of Community Affairs. I mean, it was such an honor to be there and to receive this recognition, and it was wonderful to be able to collaborate with other counties and exchange these ideas. And we not only believe in this program and the impact that it has, but it was just so cool to be able to sit at a huge banquet table and we get to talking to all of these other communities. And because we have the benefit of having both the rural and community urban communities and the needs that are required of both, it was really great to connect. And in talking with these people, and Jessica and I are speaking to this program, that program, everything we do within, not just in the BHASO, but broadly within the system of care. And one by one, you could see these county commissioners like taking up a pen and a notepad, and they're just jotting down ideas and getting our contact information. And so, Justin touches on, again and again, how we have these innovative solutions, and it really was demonstrated, and I think really recognized as we were speaking with all of these other people and the challenges that they're trying to address. So with that, we're currently finalizing our data analysis. My kitten is apparently very excited about this data because he just suddenly activated and he's meowing. So sorry if there's noise. Very exciting. And in looking at the data thus far, this data reflects what I know that everyone is seeing in our community, that our students in school are grappling with a variety of behavioral health concerns. We know this, we see it in so many different realms. If we're able to find a silver lining within that, it would be, I think that the research that we've been doing, the data we've produced over the last year is really empirically supported and aligns with other measures that like the state's using, for example, like the Healthy Youth Survey. And actually with the Healthy Youth Survey and data back in 2021, 40% of 10th graders reported feeling so sad or hopeless for 2 weeks or more that they stopped doing their usual activities. And in our own screener, we found that our data exactly aligns with 44% of high school students reflecting the same thing. Alongside that, nearly half, both middle schools and these high school students were requiring a tier 2 or tier 3 intervention. And Nancy, I don't know if you have a chance to pull up we have a risk categorization chart. If not, we can send that out, no problem. Just to kind of break down what we mean by that tier 2, tier 3 in terms of high risk behavior, those interventions that are required immediately by the end of the day versus within a near time frame in the next week or so. And so I actually was formerly a child, youth, and family therapist, and I was embedded within middle and high schools. And I, like, in being able to do that and seeing the positive impact that you have in building relationships with students and helping them like directly through their issues and providing that support, like that's really amazing. And you're making these kids feel, seen and heard. And that's not only the benefit of like directly with the relationships you get to have with them, but over the course of the year, as you're providing those students support, they're also referring their friends and helping to bring the other kids along with them. And so they're also, evangelizing the support that, they're really benefiting from, and just the impact that has. And certainly we're getting the same feedback as we have gone through this program this whole year. Josh was able to gather some qualitative data on that, and I will turn it over to him so he can speak a little about that very quickly.
Yeah, no problem. Thanks, Katie. So our end of year report will be specifically for Centennial Middle School and West Valley High School, but we are already in the process of expanding the program to additional schools based on early data and then just support within the community and even up towards executive leadership as well. So really thankful for that and look forward to continuing to provide you all updates. But as we know, I mean, numbers are great. It's obviously kind of what helps support programs, but recognizing that these are individuals and students really being impacted by the program, I feel it's great to kind of share the impact that this program has had on them. So we had asked some of the school administrators to provide some just kind of quotes from the program throughout the year on what it meant to them and what they've heard from student population as well. Some of those quotes are, the ISW project allowed us to serve the whole child. So really looking at mental health and reducing that stigma within the school population. And then the ISW project allowed us to finally start to have an answer to the mental health needs of our students, was one of the quotes from the administrators. And then for students, one of the quotes was, "It's about time that the school starts to look at mental health and take it seriously." And then one that was just, I thought, really impactful, which speaks to just the greatness of the program and how many students being served that maybe staff wouldn't even be aware of that had concerns. one quote from a student was, because of ISW, I was able to get the help that I need to, and I don't feel like hurting myself anymore. And so I think what we're seeing throughout our community and just the increase in self-harm and suicide risk, having programs like ISW specifically address that on a proactive level of really trying to get that information up front where it's implemented throughout an entire grade level. So everyone takes the screener unless they choose to opt out. Really provides great information, and then our funding through mental health sales tax dollars allows us to have clinicians on site to follow up with those students based on answers to the screener. So I like to share those quotes because I think it really touches on the heart of the program and the goal of serving the youth in our county. And I could talk for a long time, but I know you guys it's 4:30, so
we'll have the opportunity for the BHAB in our future updates, but I wanted to let the board know we're completing that, and the results are beyond what we had initially meant, which is why we are expanding. So very appreciative of the BHAB for supporting us in that area. Who would have thought a little thought in my head 3 years ago would morph into this, but it just speaks to where our department is going in Spokane County in really innovating and revolutionizing how we do mental health from a county perspective. We're not doing old school stuff. We're really looking at what is needed and responding. So thank you, Josh and Katie. And then quickly to wrap up, OAC, which is the Opiate Abatement Council. This has to do with the opiate dollars that the state got in settlement, both with the various different companies and with Washington State's one MOU. Essentially, pharmaceutical companies where the state negotiated a settlement with, those get parsed down to the county and the county receives this funding. So Spokane County and the municipalities within our 6-county region, there's 9. So each rural county plus the 6 or 5 municipalities in our county, Spokane County, because they're the largest ones with the population. Liberty Lake, Area Heights, Spokane Valley, Spokane City, and Cheney, they all agreed to Spokane County's proposal, which we discussed last time, for the county, which is the ASO, to be the Opiate Abatement Council, or to at least facilitate it. The county gets sole discretion, and so do each of them for their money assigned to their municipality. But Spokane County will be overseeing the OAC and their funding portion. The county will be designating that in the near future, and there is a certain pot of money that they have yet to allocate based on priorities. Our department will be pushing forward priorities to the county, but they will also be hearing from other community members. And so that will be coming forward, yet to be determined how they will receive those, either through our department or direct engagement. I'm assuming they're going to accept both. But we are working on various priorities. I believe the BHAB will receive those, and the BHAB will have the opportunity to express them. So I wish I could provide more, but the county has finally received confirmation from the municipalities that will agree to support this. We have yet to actually have a meeting or to functionalize a setup. Thankfully, the OAC will be overseen by professionals from the field, directed by their municipality, but it has to be professionals directly involved in it. So it'll be hopefully led by, and the priorities generated by, individuals with experience. That does not mean clinicians, it can also be lived experience. So not much more to share on that, except for more to come. I hope to have a more definitive answer for you in September. So that's our quick update. And as always, it's long around these times. Kim, back to you.
Yeah. Hey, thanks, you guys. Those were fantastic updates. It is really nice that we are in a really progressive county of the state and making some great changes. So thank you all for your work in that. Folks, any questions for Josh, Katie, or Justin before we move on? Okay, Tom, the floor is yours.
I have here my CCP minutes from May and June. First I'll do May. At this meeting, our guests were Kaylin Roy, a liaison between the BHASO and CCP, and Gail Kogel of the Office of Behavioral Health Advocacy. Brent Smith, CCP Chair, facilitated the meeting. Also attending were CCP members Tom Goss, Aaron Smith, Sarah Leak, and Robin Stegner. Sophia Alexander had excused absence. The online May 2023 CCP meeting was called to order. The April CCP meeting minutes were read and approved. There was no April Behavioral Health Advisory Board meeting, so this was not reported on. We did a general update of the Jaunt in June, a walk-in event put on by the CCP. It was noted we have 10 tables and 3 canopies available. We need to purchase raffle prizes, side make materials, bottled water, and balloons, etc. We decided to meet at Brent's apartment complex on Saturday, May 13th at 11 a.m. to work on the signs. Also, the purchases at Walmart and the dollar store have been approved. The dollar store is right next to the Walmart. Brent, Aaron, and Kaylin will meet at the Shale Walmart to make the purchases. Robin said that we might be able to purchase everything for around $150. We decided to purchase the stuff online so we don't have to shop. Brent said that he has coolers and that he will talk to Carlos Zavalli about advertising in a microphone. Aaron talked with Channel 2 about advertising. She said they might do a story on TV about the Jaunt. Sarah said Wandermere might do a free radio ad. It was noted that Spokane Evergreen Club said that they will attend the Jaunt. Gail said that she will contact the Mara Group and Community Health Plan of Washington, and she will let Robin know of other groups might attend. Robin said that she will contact Lutheran Community Services and the EWWSU student nurses. Sarah says she will contact Compassion Addiction. Aaron said she will contact Passages, Catholic Charities, and Children's Helping Hands. Brent said that he could not get a hold of Humana. Robin said that she will put the Jaunt flyer on the Facebook page, suggests that we share it. The Jaunt is scheduled for Tuesday, June 6, 2023 at the main Virginia Health Center, Mary Higgins Building from 11 o'clock to 1:30 p.m. The next CCP meeting will be held online on Monday, June 12, 2023 from noon to 1 p.m. Meeting was adjourned. And I have here my minutes from June. At this meeting, our guests were Gail Cole of the Office of Behavioral Health Advocacy and Kaylin Roy, liaison between the BHASO and CCP. Brent Smith, CCP chair, facilitated the meeting. Also attending were CCP members Tom Go, Sharon Smith, Robin Segner, and Sarah Lake. Sophia Alexander had an excused absence. The online June 2023 CCP meeting was called to order. The May CCP meeting minutes were read and approved. We discussed the May Behavioral Health Advisory Board meeting. At this meeting, there was a presentation about the Initiative for Student Wellness in SB-SBIRT update by Josh Henderson and Katie Rice. This initiative uses a universal screener which takes 10 or 15 minutes to do and determines what students' needs are. There was an administrative update by Justin Johnson. Justin gave information on the BHTSP, or Behavioral Health Treatment Support Pilot Project. This project provides what traditional therapy models cannot. Justin said that NAMI is trying to become funded again and that MRSS, or Mobile Response Stabilization Service, may expand services from 72 hours to 8 weeks. Justin said that the ARPA and BASE grants target areas needed such as substance use disorders, etc. Grants have up to 2025 to use funds and begin in July. Justin mentioned this peer respite program, a peer respite run by peers. This is for peers involved in a non-medical crisis. Peers can stay for 2 days. The Youth Inpatient Navigator program was mentioned. Youth boarded in an emergency room. It is a large program with a steering committee. All people involved develop a crisis plan. The Opioid Abatement Council, or OAC, was mentioned. Washington State has won open dollars to be dispersed over a 17-year period. Spokane received a large amount of the opioid dollars. Spokane will want to create an OSC which will have a say in funding. Justin Johnson then said that he has been confirmed as Director of Community Services Department. The board mentioned that Jim Myers has passed away. We discussed the recent Jaunt in June, a walk-in event the CCP does. Brent thanked everyone for their participation. Brent said that the Jaunt was not the biggest, but was successful because we were on Creme too. Sarah was happy with the turnout. Gail thought it was great, but wished that more consumers would have attended. Robin said that vendors attended, but that we should try to have more consumers attend. Brent said we need to print more flyers and leave them somewhere so people can have them. We discussed the coming Santa picture event the CC planned to do. Brent said we should get out the flyers in October or November if we know the day and time of the event ahead of time. Sarah said the CCP should get together a week or two in advance to prepare. It was suggested that we do the Santa pictures in Brent's apartment complex as well as the Quality Inn. December 9th was mentioned as a possible date for the pictures. Gail then gave a brief update on the Office of Behavioral Health Advocacy. Gail said the Ombuds call volume has increased and that there has been more activity. Gail said that somebody is going to be hired to do the ombuds part so that Gail can focus on director work. Gail also suggested that somebody send thank you cards to the providers who attend the jaunt, and Gail said that we should invite Krim to the Santa event. It was mentioned that a possibly new member, Sean LeBlanc, has filled an application to join the CCP. Robin then said that she opened a chat on the CCP Facebook page. Brent mentioned that Robin does a good job on the page. Next CCP meeting will be held online on Monday, July 10th, 2023, from noon to 1 p.m. Meeting is adjourned. That's my minute. That's it.
Thank you, Tom. I appreciate that. Any
You're welcome.
questions for Tom? All right. How about any board comments or public comments?
One real quick, there was articles about Daybreak in today's paper, and there's been several articles about Daybreak, the closing of it, in Sunday's paper.
Yeah, thank you, Craig. Anything else? Anything for the good of the group? Any other announcements or anything? All right, folks, we'll appreciate your being here today. We'll meet again in September on the 25th. So have a wonderful summer. Enjoy. Thank you, everyone, for being here.
Thank you.
Thank you.
Thank you, everyone.
All right.
Thanks,
Bye-bye.
everybody.
Thank you.
Bye-bye.
Thank you. Goodbye.